Thank you, Visves. And by the way, you pronounce my name well, because it's Dutau. Yes, in French, A and U sounds O. That's great. You see it? You see my presentation? Yeah? I don't hear.
Not yet. You need to share your presentation.
But it's on the screen. What? Ah.
You need to press the share screen button.
Okay. I see here. And now, yes. You see?
Yeah, we can see it, sir. Yeah.
So, okay. Again, thank you very much, Visves, for your presentation, your overview, your invitation. It's nice to see again my friends, Patabi, Ravi, and all of you. So I will speak about the management of malignant central airway obstruction, and I will, I would say, avoid the endless and useless discussion about which techniques to use. Do we have to use thermocoagulation? Do we have to use laser? Do we have? I think these are useless controversies. The most important is the result at the end. Whatever the technique you use is the result you get. So I will probably repeat some of your data, Visves. And the first one is that malignant airway obstruction is a frequent situation. In the past, it used to happen in 30% of people presenting with lung cancer. Now you see it has decreased to the last publication from my friend, David Breen from Ireland, has seen only 14% of central airway obstruction with lung cancer. And this is probably due to a shift from the central squamous cell carcinoma to more peripheral adenocarcinoma since the last decades, different kind of smoking. But by the way, it's still a frequent situation because lung cancer is still, at least in France, is the first cancer for men and for women. So it's a frequent situation for us. As you said, Visves, it can present as a endoluminal obstruction, eccentric compression, or sometimes mixed compression. The fact is that these people suffering from that have a reduced survival, very bad quality of life, and above all, this kind of obstruction can jeopardize oncologic treatment like chemotherapy, radiotherapy, because of respiratory failure, infections, atelectasis that can prevent radiotherapist to focus on the tumor. And talking about oncologic treatment, we know from the literature is that if you expect chemotherapy or radiotherapy to relieve compression and quickly relieve compression, then you know that it won't work. Or at least in only 20% of cases, you can reopen an airway compressed or obstructed by a tumor. So, as interventional pulmonologists, we have a real role to play in the management of lung cancer, and we can palliate obstruction at each step of the disease. It can be neoadjuvant, and that's very interesting because last year we've started a French registry regarding rigid bronchoscopy in obstructive lung cancer. And one of the first data which I was interested me is that therapeutic bronchoscopy is the first treatment of lung cancer in 30% of people. So that means they enter the disease with dyspnea, sometimes distress, and the first treatment of lung cancer will be therapeutic bronchoscopy. So that's very interesting to know. At least in France, that's a reality. Then, of course, it can be adjuvant treatment in parallel with oncologic treatment. And unfortunately, it can also be palliation when all oncologic treatment have been exhausted. Again, I won't go too much into detail, but the techniques we use in Marseille, so the people who came to Marseille know it, is mechanical debulking, but in Marseille it is laser-assisted mechanical debulking. And you see here the different step of of this obstruction. You see first picture A, a tumor obstructing the trachea, then a tumor devascularized with laser. On figure C, you see the coring with a bevel bronchoscope. Then on figure D, it's a removal of a large piece of tumor with a rigid forceps. On E, you see the tumor. And the last step, figure F, will be the coagulation of the basis of the tumor. This is something that can be achieved very fastly, quickly, and safely with a rigid bronchoscope. And it lasts only, no more than 30 minutes. Thoracic bronchoscopy, which are the expected results of that? You can expect immediate debulking in about 90% of the cases, lung function improvement, benefit duration. Benefit duration is lasts only 3 months before recurrence or local recurrence. Survival improvement is probable because there is nothing in the literature, no evidence-based medicine, because there is no comparative study between I debulk, I don't debulk, because it is clearly not non-ethical nowadays. And you, of course, you reduce the risk of respiratory failure with a vital risk of the procedures in the literature, roughly 0.3 to 2.7. Stenting will be proposed in case the main indication is excess incorporation, because when you have excess incorporation, you cannot debulk, you cannot core anything because it's behind the wall, or obstruction of more than 50% after debulking of the interesting part of the disease. We have plenty of data in the literature stating that you have a clinical benefit of that. You improve lung function, but again, lasts only 4 months before the stent itself can be invaded by the tumor, either on the proximal edge or at the distal edge. I don't know if I have time to show you the movie. I can this was, or a movie of what can be done. It's interesting because it's a movie recorded by Dr. Dumont, well, a few years ago, but it's still actual. You see here the bevel of the rigid bronchoscope, here, and you see the effect of laser. So laser, in Marseille at least, is used with low power settings. The aim of laser is not to vaporize the tissue, but it's to prepare the tissue to mechanical coring. In fact, we don't use laser with high power settings because, well, vaporization can be dangerous. You can eventually perforate the wall and make fistulas. So laser is only used to assist mechanical coring. So once devascularization is deemed acceptable, then the coring is performed. You see the bevel bronchoscope follows the bronchial wall and core a big piece of tumor that can be removed using the suction catheter like this. Once the internal part of the endoluminal part has been removed, then laser can be used to coagulate the tumor. Here there is a middle lobe and here is the lower lobe. And because the lumen was less than 50% of the stent is placed, here is silicone stent. And so in the whole procedure, you reopen and you can place a stent for long-term duration of reopening. Here the stent is reopened with using a balloon dilation. Well, this is an example of what can be done with rigid bronchoscope, stent, and laser. Maybe you can think that I'm a bit biased because I'm in Marseille, I've been trained by Dumont, but I'm not the only one stating that rigid bronchoscope is very useful for the management of central airway obstruction. Here a study by Mahmoud and all, Respiration 2015. you see clear clinical improvement in this prospective study in lung function data, dyspnea, and quality of life, with maximum safety and using silicone stents. I don't know if Prashant has joined us, but this is a very important study that he published in 2006. And he showed that if you compare a group with the same stage of the disease, group A with a treated central airway obstruction, successfully treated central airway obstruction, if you compare to patient without central airway obstruction, so if you are able to successfully debug, then you offer the patient the same survival curve, which is in fact not very nice, but it's the same with or without central airway obstruction. But the question I have now, again, is not about which technique to use, but it's about the prerequisite of a successful procedure. We already know that you need several items. First, as you mentioned, Visves, is a proximal obstruction. Proximal obstruction is trachea, mensa bronchus, bronchus intermedius. The disease has to be localized. Localized, that means that behind the obstruction, you have to have functional bronchi and lung parenchyma behind the obstruction. It's very important that to add that you need a functional pulmonary artery. Otherwise, you can the ratio between ventilation and perfusion could be wrong. And the last point would be performance status enough to enjoy the clinical benefit. I mean, if you propose this obstruction to someone with PS4 on the bed 100% of the time, then I think it's useless. And something I didn't say, I didn't write, it's very important, is that to recall that it is symptomatic treatment. Symptomatic treatment means that you need symptoms to propose this obstruction treatment of central airway obstruction. And as you said, Visves is mainly dyspnea. Dyspnea is probably the main symptoms that we have to focus on. So, in other words, when we have this kind of chest X-ray with a complete atelectasis of the right lung, is it the good situation here where you have localized disease, central airway obstruction, with safe bronchi and probably safe parenchyma behind, or this situation where what you see in your bronchus is just a visible part of the iceberg? So can we predict that we will be successful with our therapeutic bronchoscopy? So, and that's very important because when you look at the registry, American registry, there is a huge gap also between the technical success, and you see in this publication by David Ost in CHEST 2015, the technical success was deemed successful. I mean, it's in 93% of the cases. But when you look at the clinical improvement, then it dropped to 48 for the symptoms and 42 for the quality of life. So there is a difference between stating that you're successful, technically successful, but sometimes you can also be clinically not successful. And it's important to consider that. In my practice, I have individualized different kind of predictive factors. You have the clinical data, imaging, and endoscopic aspects. Again, symptoms are very important, and dyspnea. One very important clinical predictive factor is acute or subacute dyspnea. That means that you have a sudden obstruction of the proximal airway. So that means that behind that, you used to have the presence of functional bronchi and parenchyma behind. Unlike this progressive dyspnea, which generally represents an obstruction from the distal growing to the periphery, to the proximal airway. And of course, in case of absence of dyspnea or only on exertion, there is probably, again, a progressive obstruction coming from the periphery and generally associated with a pulmonary artery constriction or invasion. When you look at a paper from the Belgium group from Mark Noppen, where they enrolled 24 patients, all successfully debugged, you look at the box score before and after, and you see that most of patients who improve have a high BOG score before the therapeutic bronchoscopy. Recently, we published, it was in 2020, in respiration, the first prospective and randomized study regarding therapeutic bronchoscopy, which is called Spock Study, silicone prosthesis in obstructive lung cancer. It was a prospective, again, study granted by the National French Cancer Institute. 9 French university centers included 78 patients. So the question was, we do a therapeutic bronchoscopy for primary lung cancer. We are successful. That means that we have more than 50% of the lumen after therapeutic bronchoscopy. And then we have randomized patients onto a group with stents and a group without stents. The question was, do the stent has a barrier effect that prevent local recurrence and hopefully quality of life? But of course, you expose patient to stent-related complication, and you're in the other arm without stent, so no stent-related complication, but maybe higher frequency of recurrence. So here is the algorithm, central level obstruction, informed consent. Then first step was tumor resection with rigid bronchoscope, and inclusion was confirmed on the operating room if final diameter was more than 50%, and all the tumoral segment could be entirely covered by the silicone stent. Then randomization, stent or no stent. And again, a clinical follow-up, 3, 6, 12 months, in parallel to the oncologic treatment. So the main endpoint was at 1 year survival without local restenosis. Unfortunately, we have not been able to answer this question because we have not been able to enroll enough patients. But we have been able to answer to a secondary endpoint: survival, quality of life, restenosis rate, and tolerance of the stent. What is very important, because in this group of 78 patients, we only have successfully debulked patients, only successfully debulked. And when you look at the Borg scale before the inclusion, it's about 6.5. So it's a very important dyspnea before treatment. And after, it dropped down to 2.5. So 4 points, which is very important. And unfortunately, with time, dyspnea gets back. One of the most important message of the study is that if patients are naive from any oncologic treatment, like never received chemotherapy or chemotherapy plus radiotherapy, the benefit for placing a stent is not present. But in case of failure of a first-line chemotherapy, then there is a very important benefit for placing a stent, so which is somehow logical, because a naive patient can undergo treatment and hopefully expect results from oncologic treatment. But after failure of a first line, then the chance of having response with oncologic treatment is very low. So a stent is useful. This is the conclusion of a Spock study. Therapeutic bronchoscopy improved for long periods the quality of life. Barrier effect of silicone stent is obvious and delays the restenosis of about 3 months. And again, no effect on patient naive from oncologic treatment. And tolerance is very good. So we can recommend from this study to insert a silicone stent in patient after efficient debulking in case of failure of a first-line oncologic treatment. Now about imaging, predictive factors. Absence or recent atelectasis. Recent means that you have a previous imaging which shows that there is no obstruction, and I would say 1 month after, 2 months after, then you have atelectasis. That's a very good factor, because that means that you have a safe airway behind the obstruction. You see on the CT scan here that is free above and behind. In case of atelectasis, CT can help, of course, to differentiate the tumor, to see blood vessels in the atelectasis, eventually a bronchogram. You can see aspects which are not very good factors, but predictive factors such as carcinomatous lymphangitis. And you also can see if there is compression or invasion of the pulmonary artery. CT scan also can be useful, but it's sometimes difficult to have it in emergency. But in case of atelectasis, you can, with a TEP scan, PET scan, differentiate tumor and atelectasis. Now about endoscopic aspects. Three items: tumor implantation, the airway beyond the tumor, and the localization of the tumor. From my practice, it's of course easier to remove endoscopically a pedicular lesion compared to a large basis. And of course, when you have a spread distally disease, it's even more complicated to expect a good result. How to have an idea about the distal airway behind the tumor. Here you have a tumor obstructing the right lower lobe, and you see just with the suction catheter you can palpate the lesion, try to consider where is the basis, and eventually pass behind. And when you see that there's a pus coming in transparency in your suction catheter, that's a very good predictive factor to have a safe bronchi behind. Other things that you can do is with a flexible bronchoscope, try to pass behind, inject saline, and try to open the airway and to see if you have a safe airway. Now about the localization of the tumor according to the location. This comes from ancient studies from Dr. Dumont, but it's again logical to see that more you're proximal, trachea, right main bronchus, left main bronchus, the better are the results. And of course, when you go distal and above all with in the upper lobes, left and right, then you have bad results. So Dr. Dumont used to say that it's because you cannot access upper lobes with a rigid bronchoscope, which is, in my opinion, not only the main reason of the bad result. In my opinion, more you go distal in lobar obstruction, less you have a chance to have safe airway behind, safe parenchyma, and generally just a lobar obstruction is not that symptomatic. So you cannot expect dramatic improvement just by reopening a lobar obstruction. Just a case, very good case, case one, just to show you the good case, I would say. On the X-ray, you see that the right hilar was a little enlarged. You see clearly on the CT scan that there is a tumor coming from the right upper lobe, obstructing the bronchus right main bronchus and bronchus intermedius, and behind it's free. So this is clearly one of the perfect case for therapeutic bronchoscopy, because you see, like in this case, you don't even have to do laser because it's already necrotic in the face. So you just core, remove, and it's done very quickly. Big piece of tumor. Oncologists, pathologists are very happy because they don't complain about the little size of the samples. And at the end, you just have to do laser on the basis of the tumor and you reopen the airway. So that's a very good case. Another case, you see a patient, 2013, yes. Patient with not very high dyspnea, only slight dyspnea. You see the CT scan, already in this slide, you see that the left bronchus is obstructed somewhere, but not proximally, not that proximally. When you look at the other slide of the CT scan, you see different things. You see that the pulmonary artery is completely obstructed, compressed. You see that the heart is even invaded here. So clearly, even before going with a bronchoscope, you can you can predict that this case won't be a very good case for therapeutic bronchoscopy. PET scan shows, by the way, that the tumor is quite localized, but again, invading the heart here and compressing the pulmonary artery. And so, not surprising, it's all invaded everywhere. You have no safe bronchi, no safe parenchyma behind the obstruction. So this patient is not amenable to a successful debulking. So in conclusions, predictive clinical factors for successful disobstruction exist, but there is no publication in a prospective way to answer properly to the question. Wood would say that you have to be clinically meaningful and you have to do it if it's clinically meaningful and technically feasible. That's a nice sentence, but in daily practice, I mean, except in case of obvious, like the cases I just showed you, obvious failure of therapeutic bronchoscopy, in some cases you have to try and see if you can do something. But again, I think that most important is you have to consider only very symptomatic patients or moderately symptomatic patients. We still have questions regarding central airway obstructions. Even in 2013, in the ACCP, Mike Simoff wrote that in lung cancer with inoperable disease and symptomatic airway obstruction, you can propose therapeutic bronchoscopy with medical debridement, tumor ablation, airway stent placement, and you can improve dyspnea, cough, hemoptysis, and quality of life. But again, grade is 1C. Question is about the real technical success rate. And you remember the gap between the percentage of technical success and clinical improvement, the timing of airway stenting. Now with the Spock study, we have a part of the answer, not in naive patient, but after failure of chemotherapy. I have to point out that the study was done with chemotherapy, and maybe the answer can be different with a new treatment of lung cancer with immunotherapy, individual treatment. The survival benefit related to airway stenting is not completely clear. I think one thing is clear now is about improvement of symptoms, parametry, and quality of life. So this is probably my last slide. Before I remind you that this year we have a World Congress for Interventional Pulmonology, but you know that in China we could not go. It will be in November. It will be presential for Chinese people, but for non-Chinese, we'll have to do like we do now with webinars. But in 2022, the COVID will be far behind us, so you have no excuse if you don't come to Marseille. I showed you the view we have, so there is no reason not to come to Marseille in 2022. I will have the chance to be co-president with my friend, Professor Astoul. So I hope I will see you in 2 years now. Thank you.
Thank you, Professor Hervé Dutau, for an excellent talk.